So when we see these patients, Joe, as we've sort of alluded to, they're often quite difficult to pick up. What differentials do we need in our head?
Well, okay. Well, I'll tell you what. Instead of me listing all the differentials, maybe I'm going to list the first one. And
all right.
One of my first.
I'll put my tea back down.
First differential for me would be: is there an aortic dissection?
Ooh.
So coming in with chest pain,
Yeah.
they're going to clearly have some shortness of breath. Perhaps they're going to have some chest pain. Few little differentiating factors there to pick out. They may have some that other kind of pain down their jaw, down their arm, whatever.
Yeah.
And some of the other signs. So yeah, aortic dissection is certainly something I would think about.
Nice. I will go for pericarditis to start. Typically, we're relieved by leaning forward. Often younger patients, often a viral prodrome, so they're a bit unwell a couple of weeks ago. What else? ECG-wise, you generally get small QRS complexes because of the inflammation of the pericardium, so it blocks the complex a little bit. PR depression you can see as well.
Yeah, that's quite sensitive, isn't it? Yeah.
It's a very sensitive sign. And obviously the ST saddling, which I think most people are sort of aware of, without any reciprocal changes. Back to you, Joe.
Okay, so I'm going to go for pulmonary embolism.
Ooh.
So another one of your emboli type.
Yeah.
You know, it's essentially the MI of the lung, isn't it? Think about that.
MI of the lung. Love it.
You heard it here first. Typically, looking at your risk factors, so you go down through your Wells criteria in a way, don't you? So any previous DVTs, long haul travel, and then all of your atherosclerotic stuff. Ongoing cancer, recent surgeries, immobilisation, etc. Sudden onset of chest pain, shortness of breath, as opposed to a bit of a gradual onset. Quite often can be a bit pleuritic, PE, so can worsen when you take a deep breath in. It can feel like it's actually worse when you press down on it, and it's in a more abnormal, atypical area. It could be a bit in the back, it could be on the right side, etc. And you usually get a desaturation, whereas you don't always get desaturation with MI, as any if you're in heart failure, really, isn't it? So yeah, PE would be something to rule out for me. What about you?
Reflux.
Yeah.
Reflux. Sort of diagnosis of exclusion, really. Yeah, typically describes as burning pain radiating up into the esophagus, although that can be the same presenting pain as an MI pain. Metallic taste is quite a good sign.
Taste,
that sort of that taste in the mouth. But yeah, generally quite difficult to differentiate, to be honest. They might have some abdominal tenderness, epigastrically. But yeah, Joe, back to you. Okay,
so getting a bit thin now. Pneumonia probably for me. So again, differentiating with that with maybe infective / viral prodrome of some sort, but cough productive of X number of coloured sputums, which we've covered on another podcast.
Boom.
Fever. Again, looking at your sepsis markers, fever, tachycardia, maybe some hypotension, unilateral crackles on lung auscultation, and obviously an ECG that doesn't show a STEMI, which is always helpful. Pneumonia, I think.
Pneumothorax for me, I think, while we're in the lungs. Again, sort of acute onset chest pain. Generally, it's either going to be traumatic related or sort of atraumatic. So you're thinking about your tall, thin, marfanoid types, or possibly your COPD patients who've got your bulla there. Asthmatics as well. Anything that's going to raise your intrathoracic pressure. Yeah, generally, again, more of a respiratory type presenting complaints, the shortness of breath, real inability to take a deep breath, and a bit of air hunger is good term, and a bit of hypoxia. Any more, Joe?
I guess lastly, thinking about it, particularly from primary care, musculoskeletal chest pain or muscular tenderness, muscular ligamental tenderness.
Keep saying muscular.
So MSK chest pain, really, really common. It does present with painful chest pain on palpation. It does present with increased pain on inspiration quite often, or a preceding traumatic cause, but it is a diagnosis of exclusion. Quite difficult to do that in out of hours or GP practice. But again, what you have to do is look at those risk factors. Now, what you're not going to do is find a 76-year-old diabetic smoker with hypertension and a previous MI, and who's come with an onset of chest pain, even if it's palpably painful and increases on inspiration. You're probably going to send them in for ECG and bloods, aren't you?
I would expect to see that patient
exactly.
in the department.
And so actually what you're doing is you're seeing that sort of 35-year-old who's had maybe a bit of a traumatic cause, has got sudden onset of sharp chest pain on the right-hand side that's painful to palpate, etc. Those are the guys that you're going to be doing, thinking about this as a diagnosis of exclusion. So you just have to be really careful and just use your brain a little bit and weigh up the history in the physical examination.
So you mentioned getting an ECG on your patients. What are the key cardinal features that we're looking for that would suggest ischemia?
So there are quite a few, really. The clearest thing that I look for, and almost, I'm almost, apart from looking at rate, I almost go and look at that straight away. Almost on my, I've been my eyes trained to the ST segments straight away often. So is ST elevation.
Yeah.
So you're looking for elevation from the J point. What we tend to say is there are some leads, V1, V2, where you can have some ST elevation in certain patients, and of course you can have benign early repolarization and all of these sort of things going on. But what we tend to say is at least a millimeter of elevation or more in 2 congruent leads, don't we? So 2 leads of the same area. So we're not looking at kind of 1 mil in a lateral lead. Well, actually, I'll say for safety, 0.5 of a mil in a lateral lead, and then in an inferior lead, there's another 0.5 or something like that of ST elevation. It's got to be a millimeter or more in 2 separate leads, really.
Often with reciprocal changes, I think is the key.
Yeah,
as well.
and I think although the issue is, I suppose, on a standard ECG, if it's just an anterior, you might not get that reciprocal change in the inferior leads because obviously you'd be seeing that in posterior. But yes, traditionally you do want to look for that reciprocal change, and that is when ST elevation becomes diagnostic, isn't it? Look for reciprocal change every single time that you see ST elevation is what we try and tell our students.
It's just a quick point I'd like to make, actually, because an F1 asked me this yesterday.
Okay.
How do you differentiate between ST elevation and high takeoff?
Yeah, it's difficult.
Basically, my response is very difficult. And it comes down to that, essentially, is there any reciprocal change?
Yeah.
And the patient, are they, if they've got chest pain and they're, 70, sort of that patient you mentioned earlier, the smoker, the diabetic, etc., then you're going to be a little bit more cautious. And high takeoff generally occurs in a younger, fitter population. It's essentially early, it was just aggressive repolarization of the ventricles, giving an ST elevation. It generally looks smoother, it looks more like a bit of a saddle, or just a smoother concave shape. Saddle's the wrong word. But certainly smoother without any reciprocal change would suggest some high takeoff.
And you can sometimes get a little notch at the J point as well, like a little notch that's quite diagnostic. ST depression, if we see ST depression, is that ST depression, just ST depression, or is it reciprocal change from a lead where there is ST elevation?
Good point. Yeah.
So whenever I see ST elevation, I look for depression. Whenever I look for depression or see it, I look for elevation. T-wave inversion is probably what I see most often. Actually, there's loads and loads of T-wave inversion, and T-wave inversion can become fixed a lot of the time, can't it? In a number of different reasons. Pathological Q waves. Now, these can again be fixed from a previous MI, but they represent quite a significant infarction usually when you're seeing them. So what we used to call a sort of full thickness MI. Importantly, again, a sign to look for, left bundle branch block. If it's of new onset with chest pain, it's an MI until proven otherwise. There are ways that you can have a look at left bundles to see if whether it's old or new, but again, I wouldn't be doing that in a patient that is really, really at risk of an MI. Just a little note here, we'll often do a V7, 8 and V9.
So always fun to ask for a 15 lead ECG and just see what the nursing staff do, because you get some funny looks a lot of the time.
Oh, do you get your people to do your ECGs for you?
I do, yes. I do.
You're led into that one, man. So V7, V8 and V9 essentially goes on the posterior aspect of the patient, and essentially tracks along the scapula. And what that allows you to look at is the posterior area of the left ventricle. The second thing to think about, if you have an inferior STEMI, is doing a V4R. So you essentially look at your V4 position, place it over onto the right-hand side, the corresponding right-hand side of the patient. And then when you print the ECG out, V4, you just put a little R on it saying V4R. And what that shows you actually is the right ventricle. So what you want to know in an inferior myocardial infarction is whether there's any right ventricular involvement, which carries a quite a significant increase in morbidity, mortality. You have to start thinking about things like boluses of fluid and contraindicating your nitrates and things like that. Because of what is essentially going to be an impending cardiogenic shock, essentially.
Yeah, it's all preload issues.
Yeah.
So moving on, other investigations then. Obviously, blood tests are something that we're going to want to be doing. Let's just wheel a few off. So full blood count, always good to look for anemia. So anemia can cause, certainly symptomatic anemia can cause angina or even a type 2 myocardial infarction, actually.
Okay. Yeah.
Use an ease just to make sure that your renal function is okay.
Your potassiums and stuff like that,
yeah.
Because actually they can cause weird-looking UCGs.
Definitely. Liver function, because, well, why the hell not? It's only £1. CRP, if you think there's an infective cause going on. I often like to get a coag hold, don't necessarily run it, but at some point, if you see that patient, maybe if the trops are negative and you sort of think, I wonder if it was a PE, you might want to add on a D-dimer. It's much easier just to bleed the patient once and get the lab to hold the coag for a couple of hours before deciding whether to run a D-dimer or not. So that's something I like to do. But troponin is sort of the key, and I think everyone sort of appreciates that we need troponins when we're assessing patients with potential acute coronary syndromes.
So I know that there's been quite a lot of change over the last few years, isn't there?
Yeah.
And so why don't you run me through that from in a kind of chronological order from, let's say, the 1960s?
Okay, I will try. No, so when I started med school, we talked about CKs. We didn't really mention troponins.
Okay, really?
Yeah. That's how old I am.
Wow.
So
Shows you that old, though.
I know. Well, yeah. So CKs also rise in acute coronary syndromes. It's one of the things that's released as the cells die. Troponin has largely replaced that, and there's lots of different troponins that you can test for. I think that it's the troponin T is the new highly sensitive one. So again, when I was starting, we used to test troponin I's, and they were a little bit more. They were better than the CKs, but just not as good as the highly sensitive troponin T. And the issue that we largely have in practice is that they're so sensitive to hemolysis, lots of other little things as well, any sort of myocardial damage, that they're often raised.
Yeah, I think I have had that experience quite a lot actually in practice, because we in the out of hours we'll get all the abnormal path stuff come back, and so you'll see a patient in a community hospital who's had a troponin for whatever reason, they got raging heart failure, and their troponin's raised, and then I'm being called because I have to go out and visit this patient to see whether they're having an MI or because they've got a TET form and etc. And you're sort of like, well, they've got chronic kidney disease and they've probably got a bit of a pneumonia and also they've got ongoing heart failure. Their troponins are going to be raised. And so it's quite difficult, isn't it? Because it's quite sensitive, but it's not very specific.
Not overly specific, no. And it's one of those things, one troponin may be helpful, but largely most of the patients that you're seeing and assessing will have 2 troponins done.
Okay, and when's that then?
So typically the first one's about 3 hours after the onset of pain.
Okay.
And then there's another one 3 hours after that.
Okay. So that's a bit annoying, isn't it? Because
it's a little bit over. It's the 4-hour window suddenly. Suddenly.
So do these patients end up getting admitted to MAU for their second trop then? Or a medical unit?
Yeah, it depends on how risky they are. So if they're sort of relatively low risk, but have got a sort of a borderline raised troponin, they might go to CDU or some sort of assessment area in the emergency department. But a lot of them, if they've got a few risk factors, then they'll go under team medicine for a second troponin just because they are high risk.
Yeah.
But really, I think the trend is key, as it is in most blood tests, to be honest. So if your troponins are static, it implies that patient's normal. So that might be, as you mentioned, the heart failure patient, that troponin of 50 may well be their normal troponin.
Last month they also had a troponin of 49.
Yeah, exactly, yeah. But really the trend is key, and what you're looking for is a rise in troponins, which would suggest that there was an acute coronary event several hours ago. What you do actually see a lot of the time as well, if it's a prolonged or a delayed presentation, you mentioned that patient with pulmonary edema, that you're managing the crash pulmonary edema. Actually, if you did 2 troponins on that person, you might see that the troponin is actually falling. And that's because they had an event weeks ago, and actually their troponin is being cleared.
Okay.
So actually anything that isn't, either a rise or a fall suggests an MI at some point. Which I think is quite important to bear in mind as well. So don't be falsely reassured by a falling troponin, because actually that implies they've had an event that they didn't realise.
We have talked about some ways in which troponins can be raised, or some pathologies that can cause raised troponins. So why don't you just list those off for us? Essentially,
as I sort of alluded to, any sort of myocardial issue. So cardiomyopathy is quite quite a key one. You'll generally see trops in the 1,000 if you've got a dilated cardiomyopathy, just because all of that tissue is being stretched and releasing a lot of troponin. Inflammation again, so pericarditis, which we mentioned earlier, can raise your troponin. Myocarditis can too, which we didn't mention earlier, but any sort of inflammation around the myocardium can cause a troponin rise. And dissections again that you mentioned, an aortic dissection can certainly raise your troponin. But then you get the other things as well. So certainly kidney patients, so your CKD, your dialysis patients, troponin's cleared by the kidneys. Yeah. So if you've got a renal impairment, your trop's going to be raised, and that's probably going to be normal for you. But even things like shock, if you're getting poor perfusion to the myocardium at some point, then you're going to be getting a slight troponin rise as well. So any cause of shock will also raise your troponin.
Any causes of shock or trop, yes.
Yeah, I know. There's too many trops and shocks and things going on.